Once again, welcome to the Talking with Your Doctor and Other Health Professionals webinar. And this is the fourth webinar in our series, Chronic Pain, Improving Life While Living It, and we're glad you're here. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability. This webinar is co-sponsored by CIRPD, ourselves, and Pain BC, and we're also working in collaboration with the Canadian Pain Coalition. It was also made possible through the support of the Direct Access Program through the BC government. And our presenters are Dr. William Godolphin and Dr. Angela Towle. Drs. William and Angela are co-directors of the Division of Healthcare Communication at UBC, which collaborates with community and academic partners to complete research and create programs which strive to improve client health professional communications. Dr. Godolphin has been a teacher and researcher for many years with projects and publications ranging across lipoproteins, breast cancer prognostic factors, clinical laboratory toxicology, laboratory automation, and medical education. He is the Professor Emeritus in the Department of Pathology and Laboratory Medicine. Dr. Towle's expertise, especially in the management of change, builds on her past experience in health services, development, and change in medical education with the King's Fund London, UK. She is an associate professor in the Department of Medicine and senior scholar in the Center for Health Education Scholarship at UBC. And we're very glad to have both of them with us today. I will hand it over to you, William and Angela.
So thank you and welcome to our webinar. Say hello, Angela.
Hello.
I thought that I had control of the screen, but I do not. Tanya, do I have control of the screen?
Yep, you should be able to just use your arrows on your keyboard to go back and forth through the slides.
I tried that.
That didn't work. And clicking on the right side or the left side of the presentation?
Here we go. So here we are. As Tanya said, we are co-directors of the Division of Healthcare Communication, which is a separate unit at the university. And the kind of stuff we do, Tanya's mentioned, ranges across a wide area, but has all of it something to do with the communications between patients and their health providers.
So hello everyone, I'm Angela and also co-director of the Division of Healthcare Communication. So as Bill was saying, our projects are designed to improve communication between doctors and patients, and they're based on a framework called Informed Sharing, which we will one specific activity is a workshop to help patients communicate better with their physicians and other health professionals. And our presentation today is based on a workshop that we developed some years ago.
We had a bit of noise on the line there. I hope that it's gone away.
Yeah, I got it. Sorry about that.
Okay. So work on talking to your doc in the medical school in the context of helping physicians learn some techniques, communication skills for getting the most out of their conversations with patients and engaging them in informed shared decision-making, about which we will have some more to say. Simultaneously with some of that work, we began work on helping patients to take a better role or a stronger role in their communications. And initially we discovered what has been a fairly long and very good collaboration with Dr. Don Cegala from the Ohio State University, who is a professor not only in communications but also in family medicine. And it was he who first had a look at the many encounters between physicians and patients in the context mostly of family care. And the things that he discovered were some things that patients did when they encountered their physicians in communication that really helped a great deal. And he defined these, and he did some work on it. And the experiments that he did were ones in which the patients had a bit of coaching beforehand, that is, before they saw their family doc, and he did some very nice trials, randomized control trials, that showed that the patients who did this, in fact, had better health outcomes. We took the work that he had done in the context of the family practice office and developed that to use the similar ideas in developing workshops that we were able to then put on in the community in the hope of reaching a wider audience and helping a larger number of people to experience a better communication with their physicians. We are currently involved with a collaboration with the Patient Voices Network out of Impact BC, who are sponsoring workshops on talking with your doctor in communities across British Columbia. And toward the end of our discussion today, we'll give you some information on how to contact those people and find out more about what they're doing. We train the facilitators for those workshops. Our overall work and the dissemination of our work has been funded over the past 16 years or more by quite a variety of people, and we'd like to acknowledge and note the fair number of different organizations or foundations that have supported this work.
So the objectives for the webinar today that you would have seen when you signed up for this series, we had two objectives. One was that you would learn an evidence-based framework for communicating with healthcare professionals, that is informed shared decision-making, and the PACE framework that was developed by Dr. Cegala that Bill's just mentioned, and that you'd learn some practical approaches to improving your communication with healthcare professionals. More simply put, we hope that you will learn some things that you can do when communicating with health professionals that will lead to better health outcomes through informed and shared decision-making. And the way that we're going to tackle this, if I could have the next slide please, is we're going to talk a little bit about what is informed and shared decision-making. We're going to present the PACE framework, and PACE stands for presenting, asking, checking, and expressing. We're going to go through each of those elements in more detail, and we're going to try to stimulate some dialogue initially between Bill and myself, but also inviting you to submit your questions around how to put these communication skills into practice. And also include in that some of the barriers and how to overcome them. And we're going to draw on our experience in the workshop with some frequently asked questions that we get. And we're going to wrap up by providing you with some additional resources that you can follow up with afterwards.
So some background to the whole business of communication and encounters with physicians. Communications is dyadic. That is, it takes at least two. And one of the most important things about this is that how we talk to others, and all of you will be aware of this, affects how they talk to us. The patient's communication affects and has an influence upon how the physician communicates. In our workshops, we often hear from the workshop attendees how they think that the doctor should do something or do that or say something in a different way. And the communication skills that physicians acquire are very, very specialized. They learn them over a substantial period of time. And they serve, as far as they can tell, their purpose. If you want to make a difference to that, the thing that you can do is change the way that you talk. Your way to influence the way they talk is by changing yours. Physicians are busy people. The average family doctor, and this is kind of a national average, sees about 20 to 30 patients per day and has about 1,700 patients enrolled. The average office encounter lasts 7 to 10 minutes. Not very much time. These are only averages. There are physicians around who may see only 10 patients a day, and there are others who may see as many as 50. There are some who may have only 100 patients on their roll, and there are others who may have 3,000 at the extremes. And office encounters may be 3 minutes or they may be half an hour. But the point is that there's very little time available. And when the physician is being very efficient and getting on with the job, many of the jobs, at least in the context of family practice, can be accomplished from the physician's point of view in 7 to 10 minutes.
And I think what we would say is that by improving your communication skills, you're able to make the most use of whatever time you have. So improving your communication can make your use of that 7 to 10 minutes as effective as possible. There's also some good evidence in terms of patients who take an active role in their healthcare having better healthcare outcomes. And by more active role, we don't just mean that you're informed about your problems and you've done the research and you take an active role in keeping healthy, etc. But it's about being more active actually in the encounter with the physician and playing a role in communicating during that encounter, rather than sitting passively and then thinking about all the things that you wanted to say or should have said or asked after the fact, as so many of us do. But the evidence, and if you're interested, we can certainly provide you with references on this, is that people who are more active are more satisfied with the care that they get. They're more likely to pursue the treatment and follow the management plan, and they're likely to get better quicker. All this is within the context of informed and shared decision-making, which is kind of the underpinning of our work. And Bill's going to go through the key elements of informed shared decision-making.
before I begin that, have any questions come in, Tanya, about what we've remarked on so far, or are people interested in further discussion about the background?
So far, I only have one question, and it's a little bit more specific to their situation around talking with their own doctor. So nothing just yet.
Okay. So informed and shared decision-making is a relatively new idea, at least by the time you're my age, it sort of seems relatively new. It came along about maybe 20 years or so ago, and it's an outcome of lots of changes in our society and changes in the practice of medicine, with the ideas of evidence-based medicine and consumerism and feminism and greater activity on the part of citizens in their own health care and so on. It is, if you like, a kind of middle ground between paternalistic nanny knows best, where the physician is knowing all and the patient obeys obediently, and rampant consumerism, where the customer is always right. The reality is, of course, that physicians have a monopoly and a social obligation that goes with it, but the monopoly is that they prescribe medicines and they do operations and things that are associated with the practice of good medicine that ordinary citizens cannot or should not do. And on the other hand, the doctor prescribes, but eventually the patient is the one who goes and has the prescription filled or does not. And having got the prescription filled is the person who takes the medicine or does not. So patients make a lot of choices themselves about the way in which they're going to behave. And often, certainly in the past, and as far as we know even today, though that communication of between what the doctor says ought to happen and what the patient actually makes happen may have some miscommunications in it. The idea of informed and shared decision-making is that the doctor is informed about the medicine aspect of the problem, that is evidence-based medicine, and is also informed about your problem in its depth and your ideas and concerns and expectations and your preferences and circumstances. So that if you hate the idea of changing your diet and the doctor suggests to you a dramatic change in diet, you might be reluctant to tell them that you hate the idea, but not quite so reluctant to go on and not follow the diet, and that's maybe a major problem. Likewise, if you don't like taking a particular kind of medicine 3 times a day, then that may be an important thing. There may be another medicine that would do almost as well that only needs to be taken once a day. If the doctor doesn't know that about your preferences, then that's a source of miscommunication. Likewise, you need to be informed, or should be informed, about at least some of the evidence for what is being prescribed, because you should understand enough of that to, if you like, buy into the kind of management of your problem that's being prescribed. And you should know what the options are and what the doctor's expectations are for the way that you're going to proceed with your problem. The consequence, if those things happen, and the doctor is informed not only about the medicine, about your problems and preferences, and you are informed about the evidence and what the options and expectations are, then the decisions can be made in partnership. We think of this as being a meeting of experts, the doctor being an expert in the medicine and you being an expert in your own person. And that brings us to PACE.
So PACE is the framework developed by Dr. Cegala based on his experiments and observations of encounters between doctors and patients in family practice, and identifying the 4 communication skills or strategies that patients can use to get the most out of the encounter. And so we're going to step through these very briefly now and then take a bit of time to ask if there are any questions coming in, and then we're going to go through each of these elements of PACE in more detail and sort of think about what they look like in practice. So the first element in PACE, P for preparing and presenting. So most people do some kind of preparation before they go and see the doc, but it's a really important part of getting the most out of your encounter by preparing for the appointment and being able to present information about you, your problem, how you're feeling. So that's the preparing and presenting. Asking, and I'll just say that although preparing and presenting is something that you would obviously do first, the other elements are not intended to be a sequence that you follow through during the encounter with a physician, but are skills that you can draw on at any time during that medical interview. So A, asking questions. Obviously, if you want information or you're not sure about something, asking questions is a fairly obvious communication strategy. Checking understanding of the information that's provided to you by your physician or health provider, and expressing concerns. They may be concerns about the treatment, or they may be concerns about what you're concerned about, your health in general. So as we go through these in more detail, we'll try to anticipate some of the commonly asked questions, but if you have any questions coming through, please send them. Tonya, are there any questions that we should be trying to answer right now?
Yes, I have gotten a few. One was about how do I talk intelligently with my doctor when on drugs that they're taking for their fibromyalgia or chronic pain that make their brain kind of foggy and unclear.
Okay. We'll try and we'll sort of address these as we go through the next part of the presentation. So if you could just give them to us now, and then we'll try and
Sure.
And address them at the appropriate time.
Sure. And then there was another one about a general question about the decisions made in partnership aspect, and they're asking for if you can give some advice on how to arrange a consultation so problems get properly discussed. Someone saying that they bring a list with all their queries and medications and new things that have arisen since the last meeting, but they still get rushed through the consultation and don't feel like their answers are questions are answered. And then another person who says that they have been to see their doctor several times about knee pain, but the doctor just sums it up saying that it's just part of his fibromyalgia, his or her fibromyalgia, and there's nothing they can do, and so they're not sure how to actually get help. So those would be the 3 that have come in thus far.
Okay, I think we'll probably be addressing them as we go through, Bill, will we, or do you want to say anything now?
Well, I'd like to respond to questions are best answered when they're asked, so I'd like to respond at least briefly to these. I think the business of how do I talk intelligently when you're having effects from the drugs, that's a major problem. The idea that pops to my mind is to practice. Have you got a sister, a brother, a good friend, a spouse that you could try beforehand to explain what it is, or and so we get a bit of practice in expressing that. The other thought that comes to mind is if you think about it beforehand and make yourself a little crib sheet, a few bullet point notes on a piece of paper that will help you to keep track of things as you go along. That's certainly the way I try to keep track of things when I'm flustered by too many things to think about and have to teach a class. I have a crib sheet with notes on it that keep me in order. For the person who has the list and still feels that they're rushed, one way of doing this might be to take the list and give it to the doctor and say, here are the things that I'd like to talk to you about, or here are the things that I'm troubled about. Would you, and invite the doctor to pick out the ones that she thinks are the most important. So you could start off with what's on the list, and he'd have an idea of how many things there are on the list. And if he doesn't have the time to deal with all of them, then you might conclude that conversation by saying, when can I see you for a bit more time to cover some more of these? Another approach might be to, when you make the appointment, to talk to the medical office assistant and say, look, I've got X number of questions or problems that I want to deal with, and I would like a little bit of extra time. Can you book me some additional ones? In response to the person who says that the doctor says that there's nothing more that they can do, maybe that's the truth. Maybe that's what the doctor feels. I don't have a quick and easy answer. But whenever that happens to me, I always bounce it to my colleague, Dr. Towle.
Well, I guess one option is to ask if there's any other person or referral or any other suggestions that the physician has in terms of other thoughts.
Okay, so we'll move on to preparing and presenting. Part of the efficiency of preparing is to think about what your concerns are before your visit and have some kind of record of what your history has been. That might have been short-term, the pain that you felt the day before yesterday, and another one you felt today, or has it been every day or every week, or something about the sequence and where and what it felt like and how it compared to the most severe pain you've ever felt, so that you can clearly describe those things that you experienced, as well as the other things that went with it. Is it associated with any aspect of the way your other things that you were doing or other things that were happening to you? And in thinking about this, and a way of helping you to think about it is to talk to someone else, again, your spouse or brother or sister or best friend, about these things, so that will help you put them in order and in the sequence of most important to you. And then concentrate on being able to describe clearly, that is, what's new and what has changed. Always be sure to make a list of the medications you're taking, and that isn't just the stuff that's prescribed, but it's the other stuff that you may be interested in, the things that you bought in the pharmacy that were not prescribed, the special foods that you think are maybe helping you, or home medicines, so-called alternative and complementary therapy. Those are all important things that the doctor should know about that you are taking, and how much you're taking and when, and so. What's your purpose on going to this? And all of this is part of the business of preparing so that when you get to see the physician, you can present things briefly and concisely and make maximum use of that small amount of time.
Well, that's all very well, Bill, but I've got a few questions here. My doctor doesn't like me coming in with a list.
Well, all the more reason to spend a bit more time preparing beforehand and get the list in your head, so that you can say those things clearly and in order, and the order of being what's most important to you.
But then, you know, my doctor always interrupts me before I've even got my story out.
Oh, yes, we know that problem. Doctors, you see, when they're making when they're listening to you tell your story, are immediately, mostly in a diagnostic mode, and they're listening for things that are of most importance, and they're inclined to check on those things as they hear them. I don't have a good answer to that, other than, again, having your story told in a very clear and concise manner, so that you tell it in sound bites, if you like, and the most important stuff in those sound bites.
And then what about there's never enough time in the visit to go through all of the things on my list?
There is never enough time, that's what it seems, and the busyness of physicians is one of the reasons for that. A couple of ideas, one I've suggested already, is that you talk to the office assistant beforehand and find a time when the doctor may have a bit more time for you to hear about those extra things. The other idea is if you've got 2 or 3 major problems you want to deal with, but you know you've only got a few minutes, rhyme them off quickly and ask the doctor which one of these is most important for us to deal with now.
Okay.
Asking. Again, as part of preparation, think about the questions that you have to ask before the visit, so you can decide what's most important for you. There's been some recent work based upon work that's been done for a long time that shows that these 3 questions, and this is work that was done in a variety of places, and it was a well-designed controlled trial, that when patients took these 3 questions and asked them, they got much more information from the doctor, and they got shared decision-making out of it that was much superior and more satisfactory to the patients. And the three questions are, what are my options? What will happen if I do nothing? That's one question. What are the benefits and harms of each of the options? And how likely are these benefits and harms to occur? And on that basis, you can be involved in deciding what is likely to be the option that works the best for you, given your circumstance and your expertise about yourself and your own behavior.
So I have a question about asking questions, and I'm worried that I might come across as confrontational and seen as challenging my doctor's expertise.
That's a problem frequently brought up in our workshops, and indeed when we examine the kind of conversations that occur between patients and doctors, patients often have very few questions. There's a really nice alternative, and we'll speak a bit more about it, and that's checking. And that's to turn your questions into a checking idea. Asking the doctor to repeat or clarify information that's unclear. It's almost like asking a question, but it can be phrased as, could you say that again? So you said I should take the pills once a day, is that right? What did you say the side effects might be? Have a little notebook and pencil with you, and write down what the doctor just said as they said it, so that you can keep track of it. Might only take a word or two, and then try to summarize back. Say, so you said that I'm to do X and Y and Z, is that right? So checking. Interestingly, if you listen to the conversations that you have with other people, or the conversations that occur around you while you're sitting on the bus, or that you hear passing you in the street, checking is one of the most frequent things that we do in ordinary conversation. We're always saying, huh, what was that? You said so-and-so? And yet, it's one of the rarest things that occurs in the context of a visit with the doctor. And that's unfortunate, because it's a really good way of asking questions and being involved in the conversation. And finally, expressing. Sometimes you may expect to have difficulty following the treatment prescribed. Express that idea. For example, medications often have frequent side effects. Side effects you might not expect, side effects you've not known, or side effects that you have known. So say to the doctor, look, I'm worried about those side effects. Or ask what kind of conflicts there might be with some of your food preferences. If your doctor doesn't know about those concerns and expectations of yours and your worries, then they can't accommodate them. They can't suggest alternative management or treatment or things that you might watch out for. So it's really important for you to express them.
So how can I make sure that my concerns get taken seriously and my doctor doesn't just say, oh, you don't need to worry about that?
How about saying, but doctor, it's really important to me. Healthcare professionals get into the healthcare profession by being caring people. And all the training that we give them enforces and reinforces that. And when you say to them that something is really important to you, they have a very difficult time ignoring that.
Before we wrap up with a little bit of information about additional resources on this topic and things that that you might do as next steps, I wonder if we have any questions, Tanya, that we can answer at this stage.
Yes. The main ones, there's been a couple, revolve around the particulars of most of the attendees that are here who suffer particularly from chronic pain or very chronic issues where they're going to the doctor very, very frequently. And most of them evolve around sometimes a doctor either telling them straight out that they think they should find a new doctor, but then they're having trouble finding doctors that are taking patients. And then also, how do you communicate with a doctor who isn't responsive to the fact that you are having chronic pain or chronic illness in that fashion, but they aren't necessarily suggesting you find a new doctor, but you're feeling like you need to? And how do you either communicate with your present doctor to make things better, or if you have any advice on finding a new doctor who might be more responsive?
That's a very difficult problem. I know that it's difficult to find another doctor in some parts of this country, and I think this is true in British Columbia. Approximately 50% of doctors are not taking new patients, and so simply to find a new doctor is not a major undertaking. The feeling of not being taken seriously or being rejected must be terribly difficult. One suggestion I would have would be take a friend or a spouse or a relative with you and talk to them beforehand about this and say that you'd like them to or talk to them about how they might be helpful in having this conversation with your physician. I think that if you feel like you're being rejected, then you need to find a way to tell the physician that that's how you feel. And I'm not pretending for a moment that that's an easy thing to do. But there are conversations that should occur that are avoided. And we all have that experience, and very often bad things happen when they are avoided. So I don't have a quick fix or an easy idea, but those are a couple of suggestions.
All right, and then just one response to that. There have been a couple of people who have just said that their doctor has specifically requested that they not bring either a list or another person to their appointments. Do you have any sort of advice for that?
Well, I hate to go here, but one possibility is to call the College of Physicians and Surgeons and make a complaint. The only other possibility I can see is to attempt to find another doctor. I think that if the breakdown in communication is that bad, that maybe the best way to do is to escape. Those are the only two ideas I have.
Yeah, I think that you know, the relationship is only going to work if there is a therapeutic relationship. Otherwise, I'm not sure that it's going to benefit either patient or doctor if there is no common ground on which they can work together. I mean, I think that if things have got to that stage, there's certainly nothing to lose by trying to engage in a conversation about why the physician has said that and what he would suggest in terms of, or she would suggest in terms of a way forward for that relationship. Because I think that often physicians think that everything is okay because their patients don't give them feedback about the fact that things are not working from their perspective. So maybe a conversation about why the physician has said that and what they would suggest as a way forward in that relationship.
The other thing that one might do is there are a fair number of support organizations certainly in larger communities. There will be a local society or association of patient activists who represent people with fibromyalgia or that variety, other sorts of disorders of that kind. And they can be a tremendous source of support because there'll be other people who've met and dealt with these same kinds of problems. And there'll be a fair number of other people, and they're often fairly wise. Well worth making contact, if that's possible, with those sorts of organizations.
So I think we'll wrap up what we have to say, and then if there are any other questions at the end and we have time, we can get to those. The workshops, as Bill said earlier, are now being put on by the Patient Voices Network at a variety of different community centres and places, not only in the Lower Mainland, but also in Prince George and Victoria. So you might contact the Patient Voices Network or go to their website to find out more information if you're interested in actually coming to a workshop and having a little bit more chance to work with some of these ideas about communication. And I guess the other place to look for further resources is on our own website for the Division of Healthcare Communication. If you go to that website, you'll find a link to videos that illustrate the PACE framework. They show interactions between a doctor and a patient that illustrate the patient putting into practice the presenting, asking, checking, and expressing concerns. We use those videos in the workshop, but they're quite self-explanatory if you want to have a look at those. And you can follow the links under the What We Do part of the website, and it will take you to a page called Talk to Your Doc, and under that you'll find a link to Talk to Your Doc for other community members, and there's a whole bunch of resources under that, including a booklet called Talking to Your Doctor. If you want the more academic references, we can also send those to you if you want more information about the research that underpins the work.
So if you do have a chance to attend one of those community workshops, you'll find them, I think, far more useful than what we can do sort of with the webinar, because there you do get a chance to interact with others and to have a really good go at using these skills. Remember that our communication styles are a deep part of us and difficult to change. They're like learning a new language. The best thing to do is one step at a time. Just try one thing new, one of those elements of PACE, and see how it goes. Small steps. That's how we learn a new language. And remember to stay on pace when next communicating with your doctor. Thanks for listening.
Great. Thank you very much, Bill and Angela. That was a very good presentation, and we had quite a few very good questions as well. So thank you very much for the presentation, Bill and Angela, and thank you everyone for attending the webinar.